So it's my job now to introduce Donna Gayles. And I'm going to say just before she starts that we had one question come up at the very end that nobody answered, which is what is MOST, which is a kind of advanced directive. This is the form, it's a 2-page form that my primary care physician and geriatrician at MedStar named Dr. Sistrunk gives me every time I go. And it is registered, it is part of your actual formal medical record. So that if you...
It stands for medical orders for life-sustaining treatment, or physician's orders for life-sustaining treatment. That's most or both.
Well, and in DC, it's actually medical order for scope of treatment, I think is what it stands for. And the idea is that it's part of your medical record, not just your legal record. And so it's actually oriented toward physicians in language that the medical professions understand.
We have a lawyer coming to one of the workshops, Gina Lynn, I don't think she's here yet, who will be talking about advanced directives of various kinds and then giving examples so that people can see what they're like. And in MedStar, for example, I'm a MedStar patient, it would be on my record if I got emergency hospitalization, they would have that most document. So with that, I'm going to, and our speaker today can also blend that in. So this is Donna Gayles, another passionate person. She's the director of the Client Relations and associate director of the Center for Health Equity for Capital Caring Health, which does hospice and other health services. She's focused on long-term care, faith-based and community organization connections, and outreach and health equity initiatives. So she spreads out from capital caring. She calls herself an ordinary woman with a passion to spread the hope of hospice to all who need it.
So, again, I've been with Capital Caring Health for 10 years, and it has been the most amazing work of my life. I've worked with Dixcy for many years now, and it's been a pleasure. I'm happy to be here because this is an indication that you want to know more, and that's wonderful for us because so many people don't have the right information about hospice. I'm very interactive, and it's not about me just giving you information because in our exchange of information, we all learn and are better for having shared this space. So when you hear the word hospice, what do you think of first? Anybody? Dying. End of life care. Thank you. If there were just one thing that you could leave this seminar with, I want you to know that hospice is not about dying, it's about living. And it's about living well until you die. We know that with an advanced illness, it can be very complicated on many levels. However, the hope of hospice is to ensure that a person and their family who's dealing with an advanced illness have the support that they need and the empowerment that they need to care for their loved one in the way that they want to. Most people don't feel capable of caring for a person with an advanced illness. I'll just share with you briefly. Again, I've been with Capital for 10 years, but in end of life and hospice services for almost 15. I want to share with you a personal story because life and death and the journey is a personal thing. But we're, in our human connection, able to support each other, able to help each other, able to do what's necessary to ensure that our friends, family, have the best experience possible. So again, 10 years for me in Capital Caring Health. My sister's a hospice nurse and has been for more than 30 years. My mom is terminally ill. She has congestive heart failure as well as kidney failure. She's dialysis dependent, but it wasn't always that way. My mother has siblings who also had advanced kidney failure. My mother always said, I do not want to be on dialysis. Always. I remember that. I'm my mother's youngest daughter. So, you know, there's 7 of us.
7 daughters?
7 children. So I'm the youngest girl. So sometimes the older siblings don't really pay that much attention to me, even though I'm a hospice professional. At any rate, my mother got very ill. She suddenly had complications with her congestive heart failure. At that time, she was not on dialysis. But after this hospitalization, during this hospitalization, I should say, she was unresponsive. She was not able to let us know in that moment what she wanted. But all of us were there with our different feelings about life and death, with our different recollections of what she said, with our different understanding of what the journey would look like moving forward. But my mother was there in need of care, in need of an advocate, and in need of help right then. That's not the time to decide what should be done at the end of life. It could have been the end of my mother's life. The doctor came to us and said, well, we could try dialysis to see if she responds. She was septic at the time. She wasn't giving any output. They were saying we could try that, not a guarantee. But if it does work, she'll be on dialysis for the rest of her life. She was 70-something at the time. All I could hear was my mother saying, I don't ever want to be on dialysis. That's all I could hear. That's all I could remember. And here I was in the middle of my hospice experience and journey and advocacy, advocating for people that I don't know daily, hearing them say, we can give your mother dialysis. And my heart beating so fast, like, I don't want that for her. She doesn't want that for her. And they're like, well, or you could take her home with hospice. However, I was a professional, so I knew that wasn't a bad thing, but it was so dismissive the way that he presented it. And my family, not hospice professionals, not all of us anyway, my brothers who, in their perception, find my mother to be a superwoman, they're like, no, we have to do everything. I could feel my heart breaking. It was a terrible experience, but the decision was made to give my mother dialysis. She continued to live, and she's still alive now. However, she still doesn't want to be on dialysis. But she is, and has to be, if she wants to continue to live. That's not the best way to live, knowing that you're living a way that you don't want to live. I say all of that to say, hospice is a way to help you live the way that you want to live until your life ends. There's a lot of confusion, a lot of misconception about what hospice is and what it isn't. Most people hear hospice and they say, oh no, we don't want that. We're not there yet. We don't want to talk about that. But it's the talking about it that helps us be better informed and make the decisions that support us in the ways that we want to be supported. When you cannot speak for yourself, what will speak for you? Yes, an advance directive, but how do you arrive there? Yes, a lawyer, but in the concept of quality of life, how you go through the journey, how do you get there? Hospice is a great way to partner with an organization that will help you on that journey, whatever that looks like. And it looks differently for every single person who's on it. Every disease process, although maybe similar, is not the same in every person. As Dixcy mentioned earlier, most people don't access hospice until about the last 7 days of their life. It's intended to provide at least 6 months, but most people don't want to talk about it until they feel there's nothing else they can do. Hospice is not a Hail Mary. Hospice is not something that you do because there's nothing else to do. Hospice is something that you do, or it's a philosophy and way to care for a person when you know you want to maximize the time that is left, however long that is. Again, it's intended to provide at least 6 months, but we've had people on service for years. My mother actually was on hospice for a year and a half. She's still terminally ill, but stable enough that she's not on hospice now. Will she need hospice again? Absolutely, but not now. And that's what people don't hear. People don't hear that you can get on hospice and graduate. People don't hear that it's not the end of life, end of the road, the day you sign up. But as Dixcy mentioned, most people access it so late that it paints the picture for those watching that hospice kills you. Hospice just doesn't work. It's only for the last several days of your life. It's not. Hospice is a part of a benefit. It's an insurance benefit that you're entitled to when you are eligible. Someone asked earlier, what does that mean? Well, it is intended for terminal illness, someone who is significantly ill and declining. It doesn't mean that person is going to die tomorrow. It means that person is at a state in their illness journey that they need extra care. That extra care comes in the form of a team. Hospice is, again, a benefit. It's not paid for out of pocket. It's paid for by Medicare, Medicaid. Most private insurances have that benefit supported. But also, because Capital Caring Health is one of the leaders in the nation for advanced illness care, we're nonprofit. And if a person doesn't have the ability to pay, we provide that care. If a doctor says it's necessary, we provide the care. So anybody can make a referral to hospice. One of the things that Dixcy brought out is that a lot of physicians do not want to have this conversation because it leads to more questions. And some physicians, as much as we love them, aren't prepared or don't want to have this conversation. Not to disparage any physicians because I honor them in the work that they do. But sometimes, like the physician in my mom's case, it's very dismissive, the approach to end of life, the approach to what can happen next, what should happen next. So if you don't have someone who's advocating for the best outcome for you or your loved one, then it isn't the best outcome for you. However, as you are preparing, as you are able to make decisions, it's time to make a plan that may include hospice services. So what are hospice services? Someone asked earlier the difference between hospice and palliative care. Well, all of hospice care is palliative. Palliative is pain and symptom management. And as Dixcy mentioned, a palliative care process can be accessed at the very first day of diagnosis. It's talking about managing pain, managing symptoms, planning. Those are things that don't have to be specific to a prognosis. However, hospice is definitely something that you're accessing at a later stage in the disease process. So if a person, let's say, has a disease such as congestive heart failure, like my mom, that's exacerbated, oxygen needed, things of that nature, the criteria for hospice is met for that disease process, that person can access the benefit based on the criteria for that disease. Now, every terminal illness has criteria as to what makes a person appropriate. I do have referral indicator cards for you guys on the back table. And for those who are watching, it's available online on our website. But this is actually a card that lets everyone know major differences between palliative care and hospice. But the referral indicator card, as I mentioned, is one that lets people know, based on disease process, what the indications are when it might be time to call hospice. It's a referral indicator, and it's very helpful because sometimes we don't think about hospice because in our minds or in the back of our minds, it's not time for it. But if you are experiencing a terminal illness or you're caring for someone who is, it may be time, even though you might not want to think of it that way. It's best to have the preparation, the support that you need on the front end as opposed to rushing to get it in a chaotic moment and people aren't prepared for what's actually next. Having hospice in place helps you to prepare. There's a team that's assigned to your care that includes a hospice medical director who would oversee the care and collaborate with the physicians in place. in your care already. You're not losing your doctor. Your primary care physician can remain in place. You don't have to replace anyone. That team also includes a registered nurse case manager who's going to be responsible for your care and the team that cares for you or your loved one. There's also a certified nursing assistant. That person will be there to help with activities of daily living, helping to continue the process of grooming and things of that nature, things that a person would normally do themselves that they may need a little more help with at the time. There's also a non-denominational spiritual support through a chaplain. Now, some people hear chaplain and they're like, no, we don't want that. We're not religious people. And that's respected. It's very non-denominational, and it is just emotional and spiritual support because we honor and acknowledge that we're multifaceted. We're not just a physical person. So that chaplain is helping with things that aren't religious, but spiritual. There's also a social worker that will partner with your family to help with planning, additional resources, things of that nature. People don't know what they need until they need it. And a lot of times when they need it, they don't have access to it. So having a social worker in place to help navigate is a tremendous blessing, and we hear that all of the time. I never thought I needed a social worker. She or he was such a blessing. And so that's wonderful to hear. We also have volunteers who are passionate about caring for those who need more care. So there's a plethora of people to support your family, not just the person who's ill, but the family, because the family goes through the end of life journey just as much as the person who's experiencing the illness, if not more sometimes, emotionally, mentally, physically. You know, there's a lot that goes into the process of caring for another person. And I honor caregivers everywhere, remotely, in place, everywhere, because it's a job that many people never thought they would have to do, and sometimes don't feel capable of doing. Hospice comes in to empower those individuals in the family setting. And family isn't just blood, it's everyone who cares for that person. Hospice comes in to support everyone so that everyone is able to go through this journey as best they can. It's different for every single person, but we're the experts. This is our 45th year, and we know what hospice is intended to be. We know what it should be and could be, and we are always pained that so many people who could access the benefit don't. In all of the United States, we're still 48th in utilization. It's heartbreaking because this is a benefit that people should access, but they're scared. They hear the word and then it's no more conversation. This isn't something that people run to the table to talk about, but we should. And how appropriate to be at Martha's table to talk about this. So I'm very thankful for this opportunity because all of you will have the right information when you leave this room. And all of you here and there are getting this information because you will need it in the future, whether it be for yourself or a loved one, but you'll have it to give to someone else if they need it. You'll have it if your family needs the support. You'll have it. And you won't hear the word hospice and say, no, no, no. I like to let people know hospice is hope. It helps you focus on being hopeful that you'll have the end that you desire. We don't just want to live well, we want to die well as well. That doesn't register with some people because some people feel dying is the worst thing, but it isn't. It isn't. Because you can live and die well. You can have the experience, just like Dixcy's 52-year-old person who was not wanting to have any more suffering. There was nothing more to stop the disease process. But what could she do to live better? Be on the porch, surrounded by friends and family, having the children graduate, and being able and present to experience those things and not laid in the hospital suffering from a surgery that wasn't going to be fruitful anyway. I ask our patients, because I'm often the first person that they talk to, what's important to you? That's what hospice does. It helps you focus on what's important to you in whatever time limitation that you have, which none of us actually know. Because we've had people come on service with weeks to live as a prognosis who outlive that 7 times over. It's our hope that everyone that we support has the outcome that they want. And as Dixcy said, the earlier that you have the support of hospice services, the earlier that you get that full embrace, the hospice hug as we call it, for the family, it helps you relax a little bit more. It helps you be present as a family. It helps you be what you want to be in the situation. As I mentioned, I'm a hospice professional. My sister's a hospice nurse. I had another sister who worked in intake. So we had a lot of hospice professionals in our family, but it helped us to be a family and not be the nurse and not be the one coordinating care and not be the one calling all of the things in all of the places. Because it's hard enough knowing that the life of someone you love is coming to an end. That's hard enough. But what can we do to make it easier, to make it better, to make it an experience that we can all look back on and be thankful? We can plan for that. And that's what hospice helps you do. So I know that there were other questions as well, and I do have some additional materials and information on our back table, but I definitely, again, I'm very interactive and I want to answer your questions because there are a lot of questions about hospice. So I'm very thankful and happy to answer.
Can you see
if I
those?
had my glasses on, probably.
Here, why don't, I can read, I'll read the first one and then we'll go to Kay. What happens when a patient needs to sign up after 6 months again and again? Is the criterion stiffer and stiffer?
That's a great question. And you don't just automatically get discharged after 6 months. We have an interdisciplinary team meeting that happens every other week for everyone that's on service, where that team comes back together and talks about how that person is progressing. So they continue to remain on service as long as it's evidence that the service is needed. So it's not just that a person gets kicked off after 6 months. That's not how it works. If a person is no longer appropriate for the benefit, then it's evaluated and then a discharge is done. But it isn't automatic cutoff at 6 months. It's reviewed regularly. And again, as I mentioned before, we've had many people on service for years because they continue to decline, they continue to need the service, and they continue to be appropriate. So the criteria doesn't get stiffer. It's the same criteria all the time, but we have to show evidence that that person who's under care continues to need the care. Pardon me.
My question is more a comment, and that is, I wonder how much of the reluctance, albeit the things you mentioned, if we don't want to talk about it, et cetera, has to do with Medicare and the insurance cabal really don't want you to know about it.
Well, there's a lot of that as well. There's a lot of ambiguity about a number of benefits, but that's just as Dixcy said, we have to advocate for ourselves. If we are empowered with knowledge and we know what we're entitled to, we can ask. And it was excellent, those questions that Dixcy presented, because we do have to humanize our experience with our professionals, our medical professionals, because they are human just like us. And to ask, okay, if you were in this situation, how would you be responding? How best should I respond? It's a different question than just getting the information, oh, well, you're sick and there's nothing else we can do. Well, there's always something. Conversation changes situations. It changes everything. But a lot of times those conversations don't happen for many reasons. But as long as we have an understanding of what we're entitled to, we can move those conversations forward and continue to do so until we get the outcomes that we want. Yes, ma'am.
Let me ask another question from the chat. How do you handle people that have no family or friends, as sometimes happens, especially with LGBTQ people?
That's a great question. Life as we experience it is for living and supporting those that we care for. Hospice is very much like a family. We have cared for many people who didn't have personal family, but we as an organization support that person as if they had all the family in the world. We become family in many cases, and we know that the end of life journey is something that is specific to each person. So there's no different care for someone that's a part of the community that's mentioned. But at the same time, we're sensitive to every person and their needs specifically. We interact with each person the way that they need to have interaction. So we care, period.
This is a very basic question,
Sure.
but can you stay in your own home
Yes,
and be
absolutely.
in hospice?
Absolutely, and I'm glad that you brought that up because a lot of people think that hospice is a place. It is not. It's a philosophy of care, and it's ideal that a person who is going through an advanced illness to stay in their own home. Lots of people are aging in place and not wanting to be anywhere else. Oftentimes, unfortunately, there are communities where a person may be significantly ill and not having the access to a lot of the things like the Village. It's a beautiful community in concept, but there are some people, unfortunately, who don't have that, and they may be declining behind closed doors, and then they go to the hospital in an emergent situation, and everything changes because their level of care has changed. They can't live independently. It's been identified at that point. They're on the radar, and everything changes for that person. And it's so unfortunate because no one wants to go to the hospital with a stomach pain thinking that maybe they ate something wrong and get diagnosed with pancreatic cancer in a later stage, and now everything's different. So it's ideal to have the support in the home. So hospice is provided wherever a person calls home. Some people do confuse the concept of a long-term care facility with a hospice. Not everyone in a long-term care facility needs hospice care. However, hospice care is available and open to be used by anyone with a terminal illness that is declining and has a prognosis of 6 months or less. Dixcy said, again, she said a year is really what we start talking about with the physician. The guidelines of the benefits say 6 months, but with comorbidities, as Dixcy mentioned, if there's a picture that can be painted, that it wouldn't be surprising that a person were to pass away within 6 months, they typically will qualify for hospice. It's an individual basis, but it's always provided in the place that the person calls home. Now, just so that you're aware, hospice has 4 levels of care. Typically speaking, we do intersect with families at the routine level of care, which is most common. However, there are situations where we connect with people in the hospital at a higher level of need. So the routine level of care is where we have an established time to come. There's a routine plan of care, and that's in place to make sure the person is kept comfortable. We have a regular schedule, et cetera. There's also a level of care called crisis or continuous care, and that is when a symptom of the disease process starts to get exacerbated and cannot be resolved with a regular routine visit. We bring at least 8 hours of continuous nursing care into the home to make sure that that symptom is mitigated, that person remains comfortable. If that is not possible, and sometimes that is the case, a person may be experiencing a symptom that just cannot be managed in the home, then our general inpatient level of care is where that person will be cared for. And we do currently have 2 inpatient units. One is on the campus of Sibley, and then we have another one in Loudoun County. When a person is under hospice care, it's really like an acute setting or a hospice hospital. It isn't intended for a person to live there. It's intended for that person's symptoms to be managed so that they can get back home and be comfortable back under their routine care. Then there's also a final level of care, which is called respite, so that the caregiver is supported in ways that are relevant to them. Oftentimes, as we're in graduation season, weddings, things happen, life continues even when you have a loved one that's ill. And you want them to be involved in everything, but sometimes they just can't go. But you have to, because you're still living the life you have to live. Well, respite is one opportunity for people to be able to have their loved one cared for in a setting that is 24 hours, allows that care to be given for up to 5 days at a time, so that person can travel with the family, do whatever, or in some cases, just sleep or whatever. Go get their hair done, have a massage, have a meal together that doesn't include running around providing care. Whatever the caregiver needs, that respite level of care under the hospice benefit allows the caregiver to be restored up to 5 days at a time. So the benefit, again, is intended to support the person who's ill, but it is also intended to support the family because it's important. It's important to make sure that everyone in the situation has the best support, has the best outcome, and that's what hospice helps to do.
Don, just one second.
Yeah.
So there was a question about hospice at home versus versus at the hospital. Sanju, if that was not answered, just add another question to the chat. I don't know if there's anything more specific. There you go.
So just for clarity, there are some situations where some hospice providers have relationship in the hospitals where they have what's called scatter beds or GIP level of care in the hospital. That isn't always at every hospital. There are different relationships where that is a possibility, but hospice is typically provided in the setting at home. So,
My main question has to do with long-term care insurance, but I had an initial question.
yes.
The 6-month limit, Dixie mentioned how insurance companies support hospice because it's cheaper. Makes sense to me. Is the 6-month limit applicable to both private insurance and Medicare, or is it just a Medicare factor?
That's a great question. The hospice benefit is a 6-month benefit. However, again, it's not an automatic cutoff at 6 months. It's evaluated regularly to make sure that the person who is under the benefit or getting the benefit is getting the maximum of the service. And if they continue to need the service beyond the 6 months, then that's actually identified and we continue. But the 6 month is a part of the structure of the benefit,
So
period.
even
Private
with private
insurance, yes.
insurance, when you start, it needs to be a 6-month prognosis. Okay, that's good.
Correct.
The other question is how well, I assume hospice is used to working with hospitals and stuff, but also long-term care. We have long-term care insurance and can visualize situations where you might be in it. And then the hospice people can kind of guide how that works and then defer a lot of the actual caretaking in the house to the long-term care personnel.
Well, that's also a good question because custodial care, which is a lot of the personal care that a person would give themselves if they were able or their family gives them, is not covered under the hospice benefit. So a lot of times long-term care insurance allows you to enable personal caregivers and they're paid through that process. It depends on what your benefit is as it relates to your long-term care insurance, but that's one way to use it in conjunction with hospice because hospice is not intended to take over custodial care. It's intended to be an extra layer of care for those who are caring for the person who is ill. So whether that be in a long-term care facility, because we do have hospice overlay in a facility as well, or if a person is at home utilizing their long-term care benefit to have personal caregivers in place, that's all fine. The benefit, the hospice benefit that is available through Medicare, Medicaid, private insurance, still allows for all of the care that's outlined or what I mentioned earlier, regardless to whether or not you have long-term care insurance or not. It's no implication. You don't have to make any changes. That's typically for the custodial care that you'll need.
But you need to let your broker know that you need these services because they don't want to pay.
That's true.
And they want to push it back. And sometimes there's a 90-day waiting period, and you don't have 90 days. And you are entitled to that comfort care with those aides, and you need to make sure they pay up immediately.
And you can get your information from your initialized start of hospice care. A lot of times, some long-term insurance companies do honor the fact that hospice is in place and they expedite it. I'm not guaranteeing that. I'm just saying that it does happen sometimes when a person is on hospice. They will waive the 90 days sometimes. We can partner that way.
There's a question, oh, sorry, Mary. There's a question in there. Is there anything can be done to get hospice for a person who is declining due to old age and not because of cancer or other terminal illness, as happened with my mother who lived to be 104 and couldn't get hospice until the last weeks of her life? What specifically can be done?
This also breaks my heart because at one point, debility and adult failure to thrive were hospice diagnoses, but currently they are not. So if a person is just aging and unfortunately just being debilitated due to age-related changes, there aren't ways for us to bring a person under hospice services for adult failure to thrive as a primary diagnosis anymore. However, if they have other things, it might not be a cancer, it could be CHF, congestive heart failure, or COPD, or something else, we have to look at it as a case-by-case basis, because we do have a lot of people living much longer and are just declining, but they do have other comorbidities that can paint a picture of overall decline and may be able to be supported by hospice. So I always say, investigate it, connect with the hospice provider, have the evaluation done. It's not a guarantee that we can bring everyone on, but we want to support everyone that we can.
I'm not up to end your time, because you're doing very well. I have a friend, she and her husband were startled, to say the least, of learning that they had to pay $30,000 for the custodial care of a brother-in-law in hospice. And I think advice from you and maybe Dixcy also on exactly how you handle this problem of negotiating with the people that might be forcing you to take on custodial care.
Well, custodial care is needed, whether you,
Yeah,
I mean,
right.
you know, whether you have hospice or
Well,
not.
I guess forcing you to pay for it.
Well,
That's a Medicare issue. We
I was
need
going to
pay
say that the
Medicare.
short
We
answer
need to
is,
vote.
yeah,
Dixcy is saying that's a Medicare issue.
yeah, I mean, the short answer is that custodial care is not covered by the benefit. That's just unfortunately the case. And custodial care is the care that the person would give themselves, or the family can do it, or they have to hire someone to do it. It is not our desire. It is the way that the benefit is actually structured at this time. It does not cover custodial care. And many people do think that, oh, I have Medicare, I have Blue Cross Blue Shield Federal, I have this, I have that. It should all be covered. I would agree, it should be, but it currently isn't. And unfortunately, all we can continue to do is advocate and express our collective voices that the benefits should be expanded to provide more. Unfortunately, right now, it just doesn't provide the custodial.
You've heard the word activist from these people. We are part of probably 2,500 members of villages in DC. We also live near the Congress. We might be able. Yeah, right. But anyway, this is an issue that's scary, because the cost of paid custodial care, which if you have no one else in your family, they're working, they're raising children, whatever, do, is a very sad thing.
And the sad thing is that 104-year-old woman, because she's not under hospice care, if she has a crisis, she has to call 911, they have to take her to the emergency room. A little frail lady has to lay on a stretcher for hours or days.
It's very sad.
And that's the reality.
It is the
I see it
reality.
all the time.
Absolutely.
And it's just heartbreaking.
It is.
And so people who get good hospice care, good home hospice care, either have Medicaid, where they have round-the-clock, Medicaid waiver aids, or you have to be somewhat significantly, financially set to pay $30 an hour for 24 hours a day, because you may have a partner who can't manage your care.
It's true. It's true.
Mine is kind of related to everything you're saying, but I had asked earlier, the language both of you use is if you're eligible. And that says there's, to me, bureaucracy involved, and somebody other than yourself or your family is going to make a decision for you about eligibility. And does that include not only the health, your situation, but also financial eligibility? In other words, if I don't have the $30,000, even though the docs say this is the next step, I'm not going into hospice. Is that true?
Just to be clear, that $30,000 isn't in reference to hospice at all. That's in reference to everyday care that you would need if you are not able to provide it for yourself, whether you have hospice or not. The hospice benefit is covered entirely by the insurance provider. Typically, of course, in private insurances, the benefit may vary based on that coverage, but Medicare, Medicaid, private insurance does have the hospice benefit. So two things. I do want to acknowledge what you said as it relates to eligibility, because it is specific to a person who has a terminal illness. Just to be honest, I mean, we have two ends of the spectrum. There are people who want hospice service but can't get it because it isn't appropriate at that time. So they're not in the end stage of a disease process, but they recognize all of the great benefit of having a hospice support. But it's not based on their health status at the time. So it isn't about finances at all. It isn't about whether a person wants you to have it or not. If by the Medicare guidelines and CMS you qualify for the service, and that's in the referral indicator card, which I do have many of them in the back if you want to have one. This outlines a number of the illnesses that are covered as terminal illnesses, and what that would look like to be eligible or appropriate. So it is assessed by a doctor, and 2 doctors have to agree that the hospice benefit is appropriate for you. So I can honestly say that there are times where a primary care physician isn't ready to refer to hospice services, but that person has a cardiologist, and now they have a heart failure issue where the cardiologist is saying, you should probably think about hospice. That primary care physician doesn't have to be the person that refers or certifies for hospice. That cardiologist could say, my patient is declining to the place that hospice is a good path for them if they want to have it. So even when a person is completely eligible or appropriate for hospice, it's still something that you have to elect to put in place. The benefit has to be elected. Many people think that, oh, well, if I should have it, it should just go into place. That isn't how it works. You have to choose to have the hospice benefit. And if at any time you decide, this is not what I want to try a new progressive treatment that may be out, that's fine. It's always your choice. You could choose not to have the hospice benefit and then the very next day choose to come back on. It's really up to you.
Dawn, and then I'm going to go to Sheridan and back to Kay.
I'm just kind of curious with all of us baby boomers lining up for the queue, how is staffing holding up?
Well, you know.
Are you drawing new nurses who want to get out of the ER?
To be honest and just very transparent, of course, the national nursing crisis is a crisis. And we are very compassionate in our care for those that we support. We're very honest to let people know what we're able to do and what limitations are. Just to be, again, very honest, you know, the nursing crisis is a crisis. And we are doing everything we can to support all of the families that we care for as seamlessly as we always have. And it's been successful so far.
Because it's satisfying work.
Absolutely.
Because nurses want
Absolutely.
to do comfort care.
Absolutely.
They don't want to do torment care.
It's true.
That's why you don't have a hard time getting staffing.
It's true. I mean, and we want to provide the very best care that we can for those families that are on the course of advanced illness. It is a very difficult time for people, and we recognize that. And again, myself being on both sides of the conversation, recognize that the support that we provide is invaluable. So it's always an honor, and I'm always excited to come to forums like this to be able to share the information, because many people don't have the right information about hospice, and it changes the way that you view it and discuss it when you have the right information. Yes, ma'am.
Just an example, I was my parents' primary caregiver, but we had hospice for both of them, 2 months for my mother, 1 month for my father. And 5 days a week, the woman came in and would cook my mother breakfast and help her grooming. But that was it for her care. For my father, let me tell you how glad I was, and he was, that I did not have to shave and shower him. It was wonderful to have this nice man show up. But that was really pretty much all hospice provided for. But I always had a phone number that I could call and say, this is the symptom, can I give more morphine? You know, and so having that number, and not your doctor, you could get through instantly, was wonderful. And when they each died, you had somebody you could call right away. They would show up, even though both parents died on weekends, and would come and declare them dead and help with the arrangement. So you didn't have to go through 911. I mean, you don't go through 911.
don't.
So it was that help, but it was not custodial care.
That's right.
That
It's
was
not
me.
intended to be. Absolutely. And I appreciate you sharing that, and thank you for that segue, just so that you're aware, again, the custodial care, whether you have hospice or not, if you age and decline and need someone to care for you, that's something you have to pay for, whether you have hospice or not. Hospice is a saving grace in those situations because it does give you an extra layer of care that you don't have to pay for, that allows for you to have some additional support in your home. Now, again, everybody's situation is different. Everyone's level of care is different because of the disease process and how things are playing out. But it's very fluid and it's customizable to what's happening with your loved one at that time. So we want to always make sure that a person has the safety net of hospice. As you mentioned, it's a number that you can call 24/7 at any time and be supported. And that's, again, the goal of hospice, not to just manage the pain and symptoms, but to empower those who are caring for their loved ones with the information and the knowledge and support that you need to provide the care that is necessary. Another thing that is very important and has proven to be tremendous help for many families is the bereavement support. Even after our physical service is no longer needed and our care extension has ended in that vein, we continue to offer bereavement support up to 13 months and even sometimes more for that family who is bereaved. So that's a part of the benefit as well. So many, many layers of support. And you're not walking alone on a journey that's already very difficult.
I'm going to give, do we have time for one more question?
Yeah, do one more question, because then we need to break.
Okay.
Okay, so mine's still this eligibility. Who decides your eligibility?
The doctors.
So 2 doctors or whatever, they say, yeah, Kay needs to go, this would be the best for her. And that's it. Then my insurance should kick in and,
Then you consent to having the care.
okay. And that relates into the woman, the feisty woman who lived to 104, and you had said, Daisy, that, you know, she would perhaps be in the hallway, whatever. What specifically would she have done so that it was very clear that she was a hospice agreed to person? What would prevent her from lying in the hallway?
If I was her nurse clinician, I would advise the family that we could start cutting back on food if she's not interested in eating, and do blood work to show that maybe her kidneys are failing, and put together some organ failure so we can justify her qualifying. I had a very low-income Latino family who put together some money to hire me to come to meet their mother with dementia, who they were taking care of for years. And I said, you know, for dementia, it's very hard to qualify because dementia is such a long disease. And I said, put your mother in, I said, I'm going to call Capital Caring, but when they come, I want your mother in bed in her pajamas. Don't, you know, talk about how much she eats. You know, I said, we're going to create a scenario so that we can say that she qualifies. And she did qualify, and they had home hospice care. And, you know, she was very borderline, but you have to, like, be creative, think outside the box, and help people qualify.
And again, we do look at a case-by-case basis. We want to care for everyone that needs the care. That is our position. We want to. We were founded by an oncologist who herself had cancer with the mindset that people who are significantly ill need care. That's our position, period. So I always say, if it's something that you want, if it's something you want for your loved one, contact us. Let us look at it. Let us talk. Let us evaluate and get that person on the radar, because even if they're not eligible at that time, we'll continue the conversation and be there to support when they are.
So I think we have to wrap it up.
I'm getting kicked off the stage now. No, I'm just
joking. Yeah.
But I'm
But
here.
it's great. Thank you
We're in the
so
back
much.
of these
This has really
materials.
been
So.
very useful. I don't see Donna.
Oh, you don't? Okay. Is it starting now?
No, it starts at 11:30.
Thank you, everyone, for your time.
Okay.